Hi, this is Kelly Mayer, and I'm here to discuss my readmission due to dehydration bariatric surgery project, decreasing emergency department visits and readmissions due to dehydration in the postoperative bariatric surgery patient. So the background to look at this issue is, of course, the deep dive at first into the increase of the morbidly obese in our population, which continues to grow yearly. Um, and currently, there are over 900 hospitals nationwide that are recognized as accredited bariatric surgery centers. This is per the Metabolic Bariatric Surgery and Quality Improvement Program that's run. The effects of untreated obesity are, of course, enormous. Chronic diseases driven by risk factors of the overweight and obese account for 480 billion in direct healthcare costs, and this was the latest estimate as of 2016. So, using bariatric surgery as a tool to help with the weight loss fight is really a successful tool. But again, it's just a tool. There's also a lot more involved with significant weight loss as far as exercising and, of course, a good diet. But we're seeing a rise in these bariatric procedures as there was over 252,000 performed just in 2018, which in that year was an increase of greater than 10%. So looking at bariatric surgeries, dehydration is a cause for concern for those bariatric patients. Dehydration is a current safety issue with increase in readmissions and emergency department visits. Many potential bariatric postoperative complications can occur, but this is one that is likely preventable and needs to really be looked at and patients be educated. So education and visual tools can assist with decreasing hospital readmissions and emergency room visits. The American College of Surgeons has listed that readmission dehydration is preventable in most cases. Looking at how this dehydration occurs is looking at the surgical changes, of course, reducing the person's stomach pouch size, and possibly having strictures, nausea and vomiting following surgery, dysphagia, and ulcers, which cause pain, which a lot of patients, of course, that would have those aren't interested in drinking because it's painful. So the number one priority for our hydration motivation safety program is starting with education. Education of the patients before, during, and after their bariatric surgery. So safety events and reasons to reduce a patient's readmissions are, of course, the cost incurred by the patients, which can be significant, even if it's an emergency room visit. Also, being exposed to illnesses, which increases the possibility of hospital-acquired infections, and hospitals lose out financially with Medicare patients, and Medicare has to follow up with copays, and also hospital readmissions can be associated with unfavorable outcomes. The stakeholders in this are, of course, again, the patients, being billed for unexpected readmissions and visits. Physicians also as well, because they are looked at with their data, and it's tracked in most cases of how often their patients are coming back for readmissions and visits, and then this can affect their benchmarking against other programs. And then, of course, Medicaid, because payments for readmissions and emergency department visits add up. Our previous practice was that our hospital wasn't using cups that were labeled with ounces and milliliters marked on them, and so patients weren't able to give an accurate report to nursing staff when they walk in and ask how much they'd had to drink in the last hour or so. There were no guidelines in practice addressing how full each patient's cup was routinely filled, and patients were educated about the importance of staying hydrated during initial pre-surgery appointments. During these visits, education about early dehydration warning signs were not discussed previously. So patients weren't educated about calling our office or surgeons on call when they had their first signs and symptoms issues with early dehydration. The proposed project initiated on the surgical unit would be the following tools would be available. We would use hydration self-tracking sheets supplied on the unit, and those would be easy to mark per hour with little cups on them for patients to mark off when they had been drinking. Each cup was listed as 4 ounces that they were marking off. A binder was also given with 30 days worth of self-tracking hydration sheets to be sent home with the patient. Phone calls to patients before surgery, the day before surgery, really encouraged drinking a lot that day to come into the hospital well hydrated before surgery, and giving a hospital logo cup filled with 20 ounces measured on size for water and sugar-free fluids during their stay, and also to be sent home with patients. We also implemented 5-ounce measured disposable cups for measuring broth and diluted juices during their stay. We supplied the bariatric bathrooms with a urine color chart, and also a copy of this was sent home with patients to remind them they needed to drink more fluids if their urine isn't light yellow, and to really look at that chart and see the darkening colors of urine and know when they're really starting to be more in trouble and needed to reach out to us. We'd also supply a card with the surgeon's office number and instructions regarding calling with first symptoms of dehydration. And then, of course, we would go over the signs and symptoms, because a lot of patients might not realize that a fast heart rate or some muscle cramps would be related to dehydration. And once again, sending a card home with visuals to assist with education as well. The benefits of making a patient more accountable immediately following surgery with these tracking sheets is they're buying in and they're seeing really how much they are taking at a time. There's no guessing game, and self-reporting early, seeing if there's issues, you can get on board with early antiemetic medications much sooner. With less time spent in the hospital, it's imperative that these patients are educated preoperatively about dehydration. The average sleeve gastrectomy is only in the hospital 1 day, and the average room-wide stay is 1 to 2 days. Then again, going over with these patients, educating the dangers of severe dehydration, and which can start out small but really become significant quick, even with acute kidney injury, having to come in and have a couple days with fluids and sodium, potassium repleted, and just little things like that add up to many days in the hospital. We chose to make our readmission goal be less than 10% for our patients, and we looked at this by measuring monthly, examining inpatient, outpatient encounters, and then also using a smart phrase added to the surgeon's office notes to ask about outside hospital visits and hospitalizations from their patients. We looked at this project and tracked the QI project compliance of using their self-tracker sheets. Got off a little slow in the beginning, with some staff not aware of where these sheets were being kept, or that they weren't supposed to be sent with part of the chart. But once that was discussed at length, you can see our compliance rose to 100%. And then looking at our hydration motivation project and looking about our patients that had returned for IV fluids in the ED, we were trying to keep our benchmark below the national average, and we were able to do that once we implemented this program. Big agenda was teaching the caregivers before we even began the program by attending staff meetings, PowerPoint teaching for the nurses caring for these bariatric surgical patients, and re-educating the staff concerning any new updated education. Looking at Lewin's model of change, the unfreezing and introducing the nurse manager and nursing staff to begin to re-educate the patients once they arrived on the unit. So just adding that extra layer of work that they were having to do to point out the sheets, give them to the patients, make sure that they had the measured cups at their bedside right away, and we're filling them all exactly at 4 ounces, so there's no guessing of how much patients were putting in at a time. And then just re-examining that and the refreezing and assessing the implementation of the sheets and the measuring cups and capturing data and seeing where where we were having issues, like we talked about in the beginning with some of the sheets not being properly put where they were supposed to be. So we lost out on data there, on just assessing how we can best help them on the unit so that this QI project was easier for them to follow through with. And educating our patients, again, preoperatively. Like I said, we need to tackle this before they even come in the hospital in their pre-education classes, because we have them as a captive audience at that time anyway, and we can go through diet stages, recognize basic needs for following up after surgery, and how to ward off and prevent complications. And the nursing impact, really holding 10-minute quarterly catch-up meetings has helped significantly. It shares with the nurses that the data that they're helping us obtain is really helping the patients, helping our numbers for the hospital, and it really gives them more of a buy-in to show that it's their assistance that's needed and is helping facilitate this. And of course, asking them questions and seeing if they feel like anything needs to be tweaked or done a little bit different, and listening to them and show them that you really value their opinions and they're listened to and acted upon as well. And these are my references, and I appreciate you listening to my program, and I hope you guys have a wonderful evening. Thanks.